Hello students. So today after the initial presentation on inflammatory bowel diseases, the pathogenesis part, today we will be discussing about the individual entities of inflammatory bowel diseases, that is the Crohn's disease and the ulcerative colitis. Coming to the definitions first. Now, ulcerative colitis is as the name suggests, it is a severe ulcerating inflammatory disease that is limited to the colon and the rectum, and it involves the mucosa and the submucosa only. Whereas, on the other hand, Crohn disease, it may involve any area of the GIT and is typically transmural. That means it involves all the layers of the intestine. Now here ulcerative colitis is restricted up to the mucosa, whereas Crohn's disease, as you see, is it involves all the layers of the intestine. Coming to Crohn's disease proper, so it was named after the American gastroenterologist Bernard Crohn, who first described it in 1932. And you also can call it terminal ileitis, regional enteritis, and granulomatous colitis are the other names for Crohn's disease. Now, how will the patient of Crohn's disease present to you? Now, when you become a clinician and you, when you are sitting at your OPD, how will the patient come and present to you? Now, usually Crohn's disease, it begins with intermittent attacks of relatively mild diarrhea, fever, and abdominal pain. Now, this pain may sometimes mimic the acute pain of acute appendicitis. And in between these periods of symptoms, there are some asymptomatic periods of, asymptomatic periods or symptom-free periods with relapses which are common. So in between your symptomatic periods, you have some asymptomatic periods also, along with some relapses that is common in Crohn's disease. Now, apart from the intestinal manifestations of Crohn's disease, there are some extra-intestinal manifestations which are important for you all to remember. These are uveitis, migratory polyarthritis, sacroiliitis, ankylosing spondylitis, erythema nodosum, and clubbing of fingers. Now, how do you remember these extra intestinal manifestations? So I give you a small mnemonic for you to remember this well. Remember your space, of which U is for uveitis, S is for sacroiliitis, P is for polyarthritis, A is for ankylosing spondylitis, C is clubbing, and E is erythema nodosum. Now, gross morphology. How will the intestinal walls or the mucosa of the intestine look like when you look at it with your naked eyes? That means usually we look into the intestine with the help of a colonoscope. So when you look into the intestine with the help of a colonoscope, what are the gross features of Crohn's disease? Firstly, the most common sites of involvement are terminal ileum, ileocecal valve, and cecum. And here the characteristic feature of Crohn's disease is you get sharply delineated areas of disease alternating with disease-free areas. So there will be diseased areas, then there will be non-diseased areas, then again diseased areas. So these are called skip lesions, where there are skipping of normal mucosa in between two diseased mucosa. Now, because of this pairing of this mucosa in between the diseased mucosa, you get a coarsely textured cobblestone appearance in which the diseased tissue is depressed below that of the normal tissue. So, since there are skip lesions, so the normal mucosa in between two diseased mucosa will be slightly at the level above the diseased area, and the diseased tissue is depressed below that of the normal mucosa, because of which you get this cobblestone appearance. And how it looks like in the endoscope, I'll show you in the subsequent slides. And the earliest manifestation, how it begins is with the appearance of an aphthous ulcer. Now, fissures may frequently develop, which may again extend to form fistulas and sinus tracts. And because of the transmural involvement or inflammation, along with edema, there is some submucosal fibrosis along with muscular hypertrophy, which ultimately leads to formation of strictures in the intestine, which may also lead to some features of obstruction. So these are the gross morphological features in the intestine. And for you to remember, well, or for you to make it easier for you to remember, there are 5 S in Crohn's disease. These are first S is skip lesions, then the stone, the cobblestone appearance, then sinus tract formation, stricture formation, and lastly the string sign on X-ray. Now, what is the string sign on X-ray? This is because of the stricture that is present in the intestine. Now, if you do a barium mill, so what will happen when the barium passes through that stricture? It gives an appearance of a narrow string. So that is string sign on X-ray. Coming to the microscopic features. Now, when you are doing an endoscopy or colonoscopy, suppose you get these features and you do a punch biopsy and look at it under the microscope after the standard processing for histopathology. So what do you see? What do you observe under the microscope? You get abundant neutrophils that infiltrate and damage the crypt epithelium, and these clusters of neutrophils in the crypts are referred to as crypt abscesses. Now, since this is an inflammatory bowel disease, it is obvious that you will get some inflammatory infiltrate in the mucosa, and this inflammatory infiltrate here is the neutrophils. Then there will be distortion of the mucosal glandular architecture. You will see the glands are distorted. They are of different shapes and sizes, do not maintain the normal, uniform arrangement. So there is some kind of distortion. And there may be some pseudopyloric and Paneth cell metaplasia, which may again occur here. But the hallmark which you need to remember for Crohn's disease is the presence of non-caseating granulomas with absence of multinuclear giant cells. Now, you all must be knowing that the commonest example for caseating granulomas here, just to refresh your memory, caseating granulomas are commonly found in tuberculosis. So the granulomas which you find here in Crohn's disease are non-caseating type of granulomas. That means you don't get a central area of caseating necrosis here. Next, coming to ulcerative colitis. Now, it is closely related to its counterpart, that is the Crohn's disease. However, the disease is limited to colon and rectum only. Okay, so when only the rectum is sometimes involved, so then you can also call it ulcerative proctitis. Now, the extraintestinal manifestations, like in Crohn's disease, are almost the same in ulcerative colitis also, but here you have to remember there is one extra feature or extra manifestation that may occur here is the primary sclerosing cholangitis, which is more common in ulcerative colitis. Coming to the clinical features of ulcerative colitis. Now, this is again a relapsing disorder, but here you get bloody and mucoid stool. So the patient will complain of bloody diarrhea with stringy mucoid material in the stool. There may be lower abdominal pain, cramps. These are vague symptoms which get relieved by passage of stool. And more than 50% have 50% patients have a mild disease, but sometimes the initial attack may be so severe so as to even constitute a medical or surgical emergency. Coming to the gross morphology here, what will you see when you do an endoscopy or colonoscopy? Here the walls of the intestine will be thin and flaccid. And the colonic mucosa may appear red and granular, and they may have extensive broad-based ulcers. Now, here I would like to mention that in Crohn's disease also you might get presence of ulcers, right? But then the ulcers in Crohn's disease are deep, knife-like, linear, deep, knife-like ulcers involving all the layers of the intestine, But here in ulcerative colitis, these ulcers are superficial. They are superficial, only involving up to the submucosa, and they have a broad base. I'll show you pictures. Then there will be isolated islands of regenerating mucosa, which may often protrude into the lumen to create some, a polypoidal structure-like effect, but they are not true polyps. Therefore, they are called pseudo polyps. Now the inflammatory process that is going on along with the inflammatory mediators, they will damage the muscularis propria and also may disturb the neuromuscular function, leading to colonic dilation and toxic megacolon. So toxic megacolon is a complication which occurs in patients suffering from ulcerative colitis. Coming to the microscopic features, the same features are almost similar to that of Crohn's disease. However, as I told you, the process is limited to the submucosa. And you have to remember that here there are no granulomas, there are no strictures, and there is no transmural inflammation. So the inflammation is never transmural, it is only limited up to the submucosa. So here in this picture you see this cobblestoning in the on your left, and these are some pseudopolyps that you can see protruding into the lumen of the intestine. In this picture on the on your left, you see these are the skip lesions of of Crohn's disease, where you get these red areas are diseased areas and in between the areas are disease-free areas. And on the right you see a continuous involvement of that begins in the rectum, and there are no skip lesions, but the involvement is continuous in ulcerative colitis. Now whereas when you look at this picture here in Crohn's disease, you see that the ulcers are linear sharp, continuing up to the muscularis propria, deep ulcers. In ulcerative colitis, you see that the ulcers have a broad base and they are restricted only up to the submucosa, and these are some regenerating islands of mucosa which may protrude into the lumen, and they are called pseudopolyps. How will you investigate? Now, investigations, you do a colonoscopy, as I told you, which will give you the gross morphological features of ulcerative colitis and Crohn's disease. Then you can do a punch biopsy followed by histopathology, which will give you the microscopic features. And finally, serology. Now, what do you see in serology? You can look for this antibody, perinuclear antineutrophil cytoplasmic antibody, or PANCA. This is positive in 75% of patients of ulcerative colitis. Whereas you can do this antibody to Saccharomyces cerevisiae, and this is usually positive in patients with Crohn's disease. Now, what is indeterminate colitis? Now, sometimes there is extensive clinical and pathological overlap, and it becomes difficult for the clinicians as well as the pathologists to differentiate between ulcerative colitis and Crohn's disease. So those conditions, or in those cases, you call it an indeterminate colitis. So that occurs in 10% of cases of IBD, and serology will help you in distinguishing there between ulcerative colitis and Crohn's disease. Why is it important to distinguish? Because the evolving treatment strategies are different for these two diseases, and that is why a definite categorization is important. Then comes colitis associated neoplasia. Now, one of the most dreaded long-term complications of IBD, it starts as dysplasia and ultimately leading to neoplasia. Now, when are the risks greater? There are some particular criteria where the risks are greater. So usually 8 to 10 years after diagnosis of after the preliminary diagnosis of inflammatory bowel disease. And in patients where patients have pancolitis, that means involvement of all the parts of the colon, and when the frequency and severity of inflammation is greater. So in these three cases, the risk of development of neoplasia is greater. So what do? You have to, because of that chance of development of neoplasia, surveillance programs are essential. So usually you start approximately 8 years after diagnosis. Since I told you the risks are greater after 8 years, so 8 years after the preliminary diagnosis, you do a surveillance, you start the surveillance program. And surveillance is usually by endoscopy and by punch biopsy, followed by histopathology. So the most important thing for you all after all these slides and all these things which I have talked about, the most important thing for you all for your theory and for also for your viva is the differences between the these two entities, Crohn's disease and ulcerative colitis. So how do you distinguish? Now, this slide actually summarizes everything which I have talked till now. So clinically, how will you distinguish? Clinically, if there is gross blood in stool, it is usually ulcerative colitis, as I told you. And even if there is mucus present in the stool, it is usually ulcerative colitis. Fistulas are frequent in Crohn's disease, leading to formation of sinus tracts, one of those S's in Crohn's disease, and they are absent in ulcerative colitis. So these are the clinical differences. Coming to endoscopic differences, what are the differences in gross morphology? Skip lesions are present in Crohn's disease. They are not present in ulcerative colitis. Rectal sparing. Now this is important. In Crohn's disease, sparing of rectum is frequent. But as I told you, ulcerative colitis, there is no sparing of rectum. The only parts that are involved mainly are colon and rectum. So rectal sparing is not present in ulcerative colitis. Cobblestone appearance, yes, in Crohn's disease, and pseudopolyps in ulcerative colitis. Coming to our part, what are the pathological differences? When you look at the type of or what nature of the inflammation, inflammation is transmural in Crohn's disease and it is only limited to mucosa in ulcerative colitis. Ulcers, as I showed you, are deep knife-like in Crohn's disease, penetrating all the layers of the intestine. However, in ulcerative colitis, they are superficial and broad-based. Granulomas are hallmark of Crohn's disease. They are not present in ulcerative colitis. P-ANCA antibody, if you do, they are present in 75% of cases of ulcerative colitis, whereas only 11% of patients of Crohn's disease have this antibody in their blood. And if you do the lastly, if you do this antibody to Saccharomyces cerevisiae, they are common in patients of Crohn's disease, but rare in patients of ulcerative colitis. So that these are the differences between ulcerative colitis and Crohn's disease, and this slide actually summarizes everything which we have talked till now. So that's all. The battle between Crohn's disease and ulcerative colitis will continue, and it gives a real challenge to the clinicians as well as the pathologists to definitely diagnose and give a proper treatment protocol, proper treatment strategy to help the patient get a cure. So thank you. That's all.